Intrauterine growth retardation, it is a condition where the fetus fails to achieve its genetic growth potential and consequently it is at risk of increased perinatal morbidity and mortality. It is a term used to describe a pattern of growth over a period of time. It has the different a normal intrauterine growth pattern has different stages. In stage 1, which is from 4 to 20 weeks, it represents hyperplasia. Stage 2 represents hyperplasia and hypertrophy, while stage 3 presents hypertrophy, where the rapid increase in the cell size and rapid accumulation of fat, muscles and connective tissues occurs. Based on the USG examination, small fetuses they are divided into two categories like healthy SGA, short for gestational age, or true IUGR there. And IUGR further can be of two types, symmetrical or asymmetrical IUGR. In symmetrical IUGR, there is uniformity or uniformly the fetus is small and the ponderal index is also normal and head circumference and arm circumference ratio is normal and also fetal length and the arm circumference ratio is also the normal. Symmetrical IUGR can be due to the congenital malformation or any intrauterine infection like toxoplasma, rubella, cytomegalovirus, herpes simplex virus, or due to any toxins or drugs. Then it is complicated. Neonatal course, it is a complicated with the poor prognosis, while asymmetrical IUGR, it is due to the growth inhibition in stage 2 or 3, that where the hyperplasia and hypertrophy occurs. It is represented with the clinical features of head is larger than abdomen, ponderal index is low, head circumference and arm circumference ratio is also increased. Asymmetrical IUGR are due to maternal diseases like chronic hypertension, renal diseases, vasculopathy, placental insufficiency. In this, the neonatal course is uncomplicated and there is a good prognosis. Diagnosis of IUGR can be clinical, biophysical or biochemical. Biophysical, the ultrasonography USG is used, while in biochemical, the HCG is raised in second trimester and erythropoietin level in cord blood is also high in IUGR. In clinically, the diagnosis is by maternal weight gain, stationary or falling during the second half of pregnancy. Then the palpation of the uterus can also lead to the diagnosis of IUGR. Also, there are various complications of IUGR in fetal: antepartum oligohydramnios, fetal distress, fetal death; intrapartum fetal acidosis, fetal hypoxia. Maternal per se fetal growth restriction does not cause any harm to mother, but underlying disease progress like pre-eclampsia, heart disease, malnutrition may be life-threatening. Preventions include various strategies like parental care, modalities for high-risk screening, protein or energy supplementation, vitamin and minerals supplementation, then prevention and treatment of hypertensive disorders, infections or anemia during the pregnancy. Now the management for the IUGR: first of all suspect the IUGR clinically, then confirm it and find out the type of the IUGR. If it is symmetrical, then the screening for the torch infections, then USG is done, and then the fetal blood sampling is done to rule out the history of any chromosomal abnormality. If it is asymmetrical, then the management depends on the how complicated is the condition, or the gestation also depends upon the gestational age of the fetus. Treatment includes maternal bed rest. This is the initial approach for the treatment of the IUGR. Then aspirin therapy is given. The use of aspirin to treat the fetuses with the IUGR is still controversial. If aspirin is used, then it may be advantageous if given to the patients before 20 weeks of the gestation. Then the hyperoxygenation, that is fetal oxygenation, is crucial for the fetal growth, which is given from outside. Then the other forms of treatment that have been studied are maternal hyperalimentation by the amino acids, nutrition supplementation, zinc supplementation during the pregnancy. Then maternal volume expansion may be helpful in improving the placental perfusion.